Next topic is septic shock. Now how the patient will present. The patient will present, he will have the symptoms. He will have high grade fever. In septic shock, you will see high grade fever. There is altered mental status. Altered mental status. Heart rate is increased. That is tachycardic and hypertensive. BP is less. So high grade fever, altered mental status, heart rate increase, that is tachycardic and hypertensive. So this will present. The patient will present with the following symptoms. Now there is a scoring system called as Q-SOFA for septic shock, and it is used to assess the shock prognostic outcome, and that includes altered mental status, BP is greater if BP is less than 100, and respiration rate if it's tachypneic, if RR is more than 22. Each one has one score. If the score is greater than 2, the outcome is poor. Now we will learn about the management. So how to manage septic shock? First, give IV fluid bolus. Followed by noradrenaline, vasopressor. Vasopressor support. And second is obtain antibiotic culture from 3 different sites before starting any broad spectrum antibiotic. So obtain antibiotic culture from 3 different sites before starting broad spectrum antibiotics. Broad spectrum antibiotics. Then next shock, we are going to see about neurogenic shock. So what happens in neurogenic shock? First we have to see spinal cord. Okay, so what happens in spinal cord? There are sensory neurons. And sensory neuron, they have sympathetic nerve fibers, and that causes vasoconstriction. So an injury to spinal cord or during RT or transected spinal cord after RTA leads to loss of sympathetic tone, because spinal cord has sensory neurons. Spinal cord has sensory neurons, which is responsible for sympathetic systems, and that leads to vasoconstriction. So transected spinal cord after RTA leads to loss of sympathetic tone, and that will lead to bradycardia, because sympathetic system is sympathetic tone is lost. So there will be bradycardia and vasodilation. Vasodilation leads to warm extremities. Hence, we don't see cold, clammy skin in neurogenic shock. And due to vasodilation, there will be pooling of blood. Pooling of blood that leads to decreased venous return, and due to decreased venous return there will be less jugular venous pressure, that is decreased JVP, and decreased JVP there will be decreased cardiac output and decreased systolic BP, and here the BP is systolic BP. So transected spinal cord after RTA will lead to loss of sympathetic tones, that will lead to bradycardia and vasodilation. Vasodilation will lead to warm extremities. Due to vasodilation, there will be pooling of blood. Pooling of blood will lead to decreased venous return, decreased JVP, that is jugular venous pressure, and hence the cardiac output will decrease, and there will be systolic BP will also decrease. Management of neurogenic shock. So neurogenic shock is managed by giving inodrops plus fluid plus leg elevation. Now the next topic is anaphylactic shock. So what happens in anaphylactic shock? Let's learn about pathophysiology of anaphylactic shock. So when we give mismatched blood transfusion, will lead to release of histamine. So there will be histamine release. And what are the histamine? Histamines are the potent vasodilator, and this, because of vasodilation, that will lead to warm extremities. Hence cold clammy skin is not seen in anaphylactic shock, and there will be pooling of blood. Due to vasodilation, there will be pooling of blood that lead to decreased venous return, decreased JVP, that is jugular venous pressure. There also cardiac output will decrease, systolic BP will decrease. So anaphylactic shock, mismatched blood transfusion will cause histamine release. Histamines are the potent vasodilators that will lead to warm extremities because of vasodilation. Vasodilation leads to pooling of blood that will lead to decreased venous return, decreased JVP, decreased cardiac output, and systolic blood pressure. It's management of anaphylactic shock. So administer IV steroids, antihistamines. Histamine release, so I have to give antihistamines, antihistaminic, and subcute epinephrine. In concentration 1:1000.